The new LinkedIn Hiring Pro can't undo your last hire. The human postponer. They were the master of one phrase. I'll circle back on that. But 3 months later, you were the one doing all their work and wondering how big that circle is. But LinkedIn Hiring Pro can take the hiring load off your plate by automating the hiring busy work from the initial job post to scheduling interviews. Hire right the first time with LinkedIn Hiring Pro. Post a free job today at linkedin.com/quality.
This episode is brought to you by Accenture. When your advertising operations fall out of sync, everything else follows. Spotify and Accenture are working together to reinvent the rhythm of ad sales, using automation, analytics, and smarter workflows to simplify campaign delivery and access better data across the business. The result? Less time spent on operations, more time connecting brands with the moments and fandoms that matter most. Learn more at accenture.com/Spotify.
Hey everyone, Chris here from MedPrepToGo, and welcome to another episode of our USMLE Step 1 Questions podcast. In this episode, I'll be reading 3 more anatomy questions from our online Qbank, and of course, you can read these questions and more at MedPrepToGo.com. Now, let's get started with question 1, Anatomy 23. A 61-year-old man comes to the emergency department because of sudden onset left-sided neck pain and headache. He has a history of hypertension and cigarette smoking. He takes lisinopril and hydrochlorothiazide. Physical examination shows left-sided ptosis and meiosis. The left side of his face is dry compared to the right side. Extraocular movements are intact, and visual acuity is normal. CT angiography shows a dissection of the left internal carotid artery. Disruption of which of the following pathways most directly explains this patient's ocular and facial findings? Is it A, parasympathetic fibers traveling with the oculomotor nerve, B, postganglionic sympathetic fibers traveling along the internal carotid artery, C, preganglionic parasympathetic fibers traveling with the facial nerve, D, somatic motor fibers traveling with the abducens nerve, or E, somatic motor fibers traveling with the trochlear nerve? And the correct answer here is B, postganglionic sympathetic fibers traveling along the internal carotid artery. This patient has Horner syndrome characterized by ptosis, meiosis, and anhidrosis due to disruption of sympathetic innervation to the head and neck. Postganglionic sympathetic fibers arise from the superior cervical ganglion and travel along the internal carotid artery to reach the eye and face. These fibers innervate the superior tarsal muscle, dilator pupillae, and facial sweat glands. Internal carotid artery dissection can injure these sympathetic fibers, producing ipsilateral ptosis, meiosis, and facial anhidrosis with preserved extraocular movements. Answer choice A, parasympathetic fibers traveling with the oculomotor nerve is incorrect. Parasympathetic fibers in cranial nerve 3 constrict the pupil through the sphincter pupillae and mediate accommodation through the ciliary muscle. A compressive oculomotor nerve lesion classically causes a dilated pupil, ptosis from levator palpebrae superioris weakness, and impaired extraocular movements, not meiosis with intact eye movements. Answer choice C, preganglionic parasympathetic fibers traveling with the facial nerve is incorrect. Preganglionic parasympathetic fibers of the facial nerve innervate the lacrimal, submandibular, and sublingual glands after synapsing in the pterygopalatine or submandibular ganglia. Injury to these fibers can impair lacrimation or salivation, but does not cause Horner syndrome. Answer choice D, somatic motor fibers traveling with the abducens nerve is incorrect. The abducens nerve innervates the lateral rectus muscle, which abducts the eye. Injury causes horizontal diplopia and impaired abduction of the affected eye, not ptosis, meiosis, or anhidrosis. Answer choice E, somatic motor fibers traveling with the trochlear nerve is incorrect. The trochlear nerve innervates the superior oblique muscle, which depresses and entorts the adducted eye. Injury causes vertical diplopia that worsens when looking down, such as while walking downstairs, but does not affect pupillary size or facial sweating. Key learning point. Horner syndrome results from disruption of sympathetic fibers to the head and neck, which can occur when postganglionic fibers traveling along the internal carotid artery are injured. Question 2, Anatomy 24. A 42-year-old woman undergoes surgical removal of a benign tumor in the pterygopalatine fossa. Several weeks later, she reports dryness of the left eye and decreased nasal secretions on the same side. On physical examination, taste on the anterior two-thirds of the tongue is intact, facial movement is normal, and pupillary light reflexes are normal bilaterally. Damage to which of the following structures most likely explains her symptoms? Is it A, ciliary ganglion, B, otic ganglion, C, pterygopalatine ganglion, D, submandibular ganglion, or E, vagus nerve? And the correct answer here is C, pterygopalatine ganglion. The pterygopalatine ganglion contains postganglionic parasympathetic neurons that supply the lacrimal gland and glands of the nasal cavity, palate, and pharynx. Preganglionic parasympathetic fibers originate from the facial nerve, travel through the greater petrosal nerve and nerve of the pterygoid canal, and synapse in the pterygopalatine ganglion. Postganglionic fibers then distribute to target glands by traveling with branches of the maxillary division of the trigeminal nerve and, for lacrimation, ultimately the lacrimal branch of the ophthalmic division. Injury to this ganglion can therefore cause ipsilateral dry eye and decreased nasal secretions without necessarily impairing facial expression, taste, or pupillary reflexes. Answer choice A, ciliary ganglion, is incorrect. The ciliary ganglion receives preganglionic parasympathetic fibers from the oculomotor nerve and supplies the sphincter pupillae and ciliary muscle. Injury would impair pupillary constriction and accommodation rather than causing decreased lacrimation and nasal secretions. Answer choice B, otic ganglion, is incorrect. The otic ganglion receives preganglionic parasympathetic fibers from the glossopharyngeal nerve via the lesser petrosal nerve. Postganglionic fibers travel with the auriculotemporal nerve to the parotid gland, so injury would decrease parotid salivation rather than lacrimation or nasal gland secretion. Answer choice D, submandibular ganglion, is incorrect. The submandibular ganglion receives preganglionic parasympathetic fibers from the facial nerve through the chorda tympani and linguinal nerve. It supplies the submandibular and sublingual glands, so injury would reduce salivation from those glands rather than causing dry eye and decreased nasal secretions. Answer choice E, vagus nerve, is incorrect. The vagus nerve provides parasympathetic innervation to thoracic and abdominal viscera through the proximal two-thirds of the transverse colon. It does not provide parasympathetic secretomotor innervation to the lacrimal gland or nasal mucosa. Key learning point. The pterygopalatine ganglion receives facial nerve preganglionic parasympathetic fibers and provides postganglionic secretomotor innervation to the lacrimal gland and nasal mucosal glands. Question 3, Anatomy 25. A 29-year-old woman is brought to the emergency department after a motor vehicle collision. She reports diffuse abdominal pain and aching pain over the left shoulder. She has no previous history of shoulder injury. Temperature is 37.1 degrees Celsius or 98.8 degrees Fahrenheit. Blood pressure is 92/58, pulse is 110 beats per minute, and respirations are 22 per minute. Physical examination shows left upper quadrant abdominal tenderness with guarding. Passive and active range of motion of the left shoulder are normal, and there is no tenderness over the clavicle, acromioclavicular joint, or proximal humerus. Focused abdominal ultrasonography shows free intraperitoneal fluid near the spleen. The patient's shoulder pain is most likely referred through sensory afferents entering which of the following spinal cord levels? Is it A, C3 to C5, B, T1 to T4, C, T5 to T9, D, T10 to L1, or E, S2 to S4? And the correct answer is A, C3 to C5. This patient likely has splenic injury with intraperitoneal bleeding irritating the left hemidiaphragm, causing referred pain to the left shoulder. Sensory innervation of the central diaphragm is carried by the phrenic nerve, which arises from spinal cord levels C3 to C5. Referred pain occurs because visceral or diaphragmatic afferents and somatic afferents from the shoulder region converge on overlapping spinal cord segments. The supraclavicular nerves that supply the shoulder region also arise from cervical levels, so diaphragmatic irritation may be perceived as shoulder pain. Answer choice B, T1 to T4, is incorrect. Upper thoracic spinal levels are associated with referred pain from some thoracic structures, such as cardiac pain radiating to the chest or medial arm. This patient's shoulder pain in the setting of splenic injury and diaphragmatic irritation is better explained by phrenic nerve afferents entering C3 to C5. Answer choice C, T5 to T9, is incorrect. These levels are associated with foregut visceral afferents, which can refer pain to the epigastric region. They do not explain isolated shoulder pain caused by irritation of the central diaphragm. Answer choice D, T10 to L1, is incorrect. These levels are associated with hindgut, pelvic, and some lower abdominal referred pain patterns, including pain from structures such as the distal colon or upper ureter. They are not the primary pathway for referred shoulder pain from diaphragmatic irritation. Answer choice E, S2 to S4, is incorrect. S2 to S4 carries parasympathetic outflow to pelvic organs in visceral afferents from many pelvic structures below the pelvic pain line. These levels are not responsible for the referred shoulder pain after diaphragmatic irritation. Key learning point: referred shoulder pain from diaphragmatic irritation is transmitted by the phrenic nerve whose sensory afferents enter the spinal cord at C3 to C5. And that will conclude this episode of our USMLE Step 1 Questions podcast. I hope you enjoyed it and found the information useful. Please be sure to follow us at MedPrepToGo on LinkedIn, Facebook, Instagram, and YouTube to stay up to date with our content. You can learn more and read other Step 1 questions at MedPrepToGo.com. Happy studying!